Today my topic of discussion is jugular venous pressure, and my moderator is Dr. Shoaib sir. What is JVP? JVP is the single most important bedside measurement from, from which we can estimate the volume status, by which we know the pressure changes which are occurring in the right heart. Anatomy. The internal jugular vein is more preferred because the external jugular vein has walls and it is not in direct continuation with superior vena cava and the right atrium, whereas the internal jugular vein has a straight line course through the innominate vein to the superior vena cava and ultimately to the right atrium. Examination of the JVP. Usually, right AJV is preferred for assessing both the waveforms and venous pressures. And what we are actually seeing are the transmitted pulsations to the overlying skin between the two ends of the sternocleidomastoid. Measurement of JVP. Initially, the patient should lie comfortably and trunk is inclined at an angle of 30 to 45 degrees from the supine position. Chin should be elevated and head should be slightly rotated to the left. Neck and trunk should be in the same line. And when the neck muscles are relaxed, shine a beam of light tangentially across the skin overlying the JV to see its pulsations. So JVP traditionally has been measured as the vertical distance between the top of jugular venous pulsation and the sternal inflection point, which is the angle of Lewis. In this position, the sternal angle is at a vertical distance of about 5 centimeters above the right atrium, and usually a distance of greater than 4.5 centimeters at 30-degree elevation is considered an abnormal JVP. Central venous pressure we calculate by seeing the JVP measurement, that is, adding 5 centimeters of water to the measured JVP. And it should also be noted that the bedside estimates of JVP or CVP are made in centimeters of water, but must be converted into millimeters of mercury to provide correlation with the accepted hemodynamic norms. That is, around 1.36 centimeters of water is equal to 1 mm of mercury. And this use of sternal angle as a reference point leads to systematic underestimation of the CVP and should be used less for semi-quantification but rather to distinguish a normal from an abnormal elevated central venous pressure. And the other methods like use of clavicle as a reference for standardization. Venous pulsation above this level in sitting position are clearly abnormal, as the distance between the clavicle and the right atrium is at least 10 centimeters. And in this, the patient should always be placed in sitting position with the legs dangling below the bedside, and when an elevated pressure is suspected, while in the semi-supine position. What are the differences between the IJV and carotid pulses? The venous waveform sometimes can be difficult to distinguish from the carotid pulse, especially during casual inspection. So we need to know the differences between IJV and carotid pulsations. In IJV, the pulsations are superficial, more lateral in the neck. Carotid, they are more deeper and medial in the neck. IJV better seen than felt, and in carotid better felt than seen. In IJV, it has two peaks and two troughs, but carotid has single upstroke. In IJV, descents are more obvious than crests, and in carotid, upstrokes are brisker and visible. And in IJV, digital compression abolishes the venous pulse, and digital compression has no effect in carotid. IJV jugular venous pressure falls during inspiration, and respiration has no effect in carotid pulsations. And abdominal compressions may elevate jugular venous pressures, and abdominal compression has no effect on the carotid pulsations. So this is the normal waveform of AJV, which is reflecting the phasic pressure changes in right atrium during the systole and right ventricle during the diastole. So as we can see, there are two visible positive waves A and B, and two negative troughs X descent and Y descent, and one more positive wave is seen, which is known as the C wave, which is interrupting the X descent. So, what are these waves? A wave. The A wave reflects the right atrial pre-systolic contraction, and it occurs just after the electrographic P wave preceding the first heart sound, and it is the dominant wave in the JVP during the inspiration, and it is larger than the V wave. So what are the abnormalities in A wave? So a prominent A wave is seen in patients where there is a reduced ventricular compliance, like in pulmonary stenosis, pulmonary arterial hypertension, right ventricular infarction, and when there is an increased resistance to right atrial emptying, like in tricuspid stenosis, right atrial myxomas, and tricuspid atrasias. This is the more prominent area as seen in tricuspid stenosis. What is a Canon A wave? A Canon A wave occurs when there is an atrioventricular dissociation and the right atria contracts against the closed tricuspid wall. Examples are like junctional rhythm, congenital heart block, and ventricular tachycardias. These are the Canon A waves seen in AV blocks. And in a patient with a white complex tachycardia, the appreciation of Canon A wave in the jugular venous waveform helps in identifying the rhythm as ventricular in origin. And A wave may not be present in atrial fibrillation. As we see, there is no A wave here in atrial fibrillation. X descent. The X descent defines the fall in right atrial pressure after inscription of the A wave. It is the most prominent motion of normal JVP. Begins during systole and ends just before S2, and it is larger than Y descent. So what are the abnormalities of X descent? Prominent X descent can be seen where there is a vigorous right ventricular contraction. Conditions may include cardiac tamponade, constrictive pericarditis, and right ventricular overload, which occurs conditions like ASD. This is the prominent X descent, as we can see in constrictive pericarditis. And in tricuspid regurgitation, the early sign is blunting of X descent, and the late sign will be absent X descent. C wave and the V wave. The C wave occurs as the closed tricuspid valve is pushed into the right atrium during the early ventricular systole, and it interrupts the X descent, and which is followed by the further descent. The V wave, it represents the atrial filling during the atrial diastole and occurs during the ventricular systole. The height of V wave is determined by right atrial compliance as well as volume of blood returning to the right atrium, either through antegrade from the vena cava or retrograde through an incompetent tricuspid valve, and it occurs during and following the carotid pulse and peaks after S2. So, abnormalities of the V wave. In patients with tricuspid regurgitation, the V wave is accentuated and subsequently fall in pressure is rapid, like you can see here. Accentuation of the V wave and rapid Y descent.
With progressive degrees of tricuspid regurgitation, the V wave merges with the C wave, and right atrial and jugular waveforms becomes ventricularized. And in other conditions where we can see these abnormalities are like in severe congestive heart failure, atrial fibrillation, or pulmonary and large ASD. These are the other conditions where waves accentuated by descent. Decline in it occurs due to decline in right atrial pressure because of the rapid emptying of right atrium into right ventricle following the opening of tricuspid valve in the early diastole. The Y descent, which follows the peak of V wave, can become prolonged or blunted with obstruction to right ventricular inflow, as may occur with tricuspid stenosis conditions like tricuspid stenosis, right atrial myxoma, or pericardial tamponade. And rapid Y descent. Elevated venous pressures, myocardial dysfunction, severe ventricular dilatations like severe tricuspid regurgitation, constrictive pericarditis, which is usually accompanied by a pericardial knock, and severe right ventricular failure and ASD with MRE. This is the slow Y descent with the prominent wave, as you know, tricuspid stenosis, and this is the rapid Y descent. This is the conclusion of the waveforms, the abnormalities of these, as seen previously. So, normally the venous pressure should fall at least by 3 mm of mercury with inspiration, by which mechanism it occurs is during inspiration there is a negative intrathoracic pressure, and this enhances the pressure gradient between the positive abdominal pressure and negative intrathoracic pressure within the thorax and the superior vena cava, which ultimately translocates the blood volume, like increasing right ventricular pressures and volume and decreasing right atrial pressure. By this mechanism, venous pressure usually falls during inspiration. Kussmaul sign. What is Kussmaul sign? Kussmaul sign is defined by either a rise of JVP or a lack of fall of JVP during inspiration. So the conditions in which Kussmaul sign can be seen is constrictive pericarditis, and in some cases of restrictive cardiomyopathy due to hypoelasticity or inelasticity of the myocardium, and other conditions like massive pulmonary embolism, right ventricular infarction due to bed right ventricular function, and advanced left ventricular systolic heart failure. It is also a common isolated finding in patients after cardiac surgery without other hemodynamic abnormalities.
Abdominojugular reflex. Venous hypertension sometimes can be elicited by passive leg elevation or performance of the abdominojugular reflex maneuver, and when these signs become positive, it indicates a volume overloaded state with limited compliance of an overly distended or constricted venous system. This abdominojugular reflex is produced with a firm and consistent pressure over the upper portion of the abdomen, preferably over the right upper quadrant, for greater than 15 seconds. A positive response is defined by a sustained rise of greater than 3 centimeters in the JVP during the application of this firm abdominal pressure. And this response should be assessed after 10 seconds of continuous pressure to allow for the respiratory artifacts and tensing of the abdominal muscles to subside. Patients must be coached to refrain from breath-holding maneuvers like Valsalva-like maneuvers while performing this procedure. And performance of abdominojugular reflex maneuver is useful in predicting a pulmonary artery wedge pressure of greater than 15 mm mercury in patients with heart failure. Although the JVP primarily estimates the right ventricular filling pressure, it has a predictable relationship with the pulmonary artery wedge pressure. In a large study of patients with advanced heart failure, the presence of right atrial pressure greater than 10 mm of mercury, as predicted on bedside examination, had a positive value of 88% for the prediction of a pulmonary artery wedge pressure of greater than 22 millimeters of mercury. In addition, an elevated jugular venous pressure has a prognostic significance in patients with both symptomatic heart failure and asymptomatic LV systolic dysfunction. The presence of an elevated JAP is associated with higher risk of subsequent hospitalization for heart failure, death from heart failure, or both. This is the pictorial representation of a JVP, the increase in JVP after performing the abdominojugular reflex. Thank you.